And the classic infectious disease that gives you granulomas are mycobacteria, and it's one of the hallmarks of an intracellular infection. This is just showing you some inflammation called this lymphocytic colitis. We don't know what causes this, but if you were to biopsy some Crohn's patients, this is what it would look like. Here's what Crohn's disease looks like endoscopically. In some cases, in severe cases. In other cases, you just see a few red spots. You see a few little red pimples that we call aphthous ulcers. But in this, you've got denuded mucosa, you've got polypoid features, and that, you may go up another 6 inches and the mucosa can look absolutely normal. Okay. Through this this isn't a big picture, I've got a bigger picture later, but Crohn's disease looks just like Johne's disease, or can. There is such a broad spectrum of disease presentation, not only inside the species of patients that get labeled with Crohn's, but in individuals. You will have some areas that look very, very minimal and others with severe inflammation. Crohn's disease can involve anywhere in the GI tract, from the mouth to the anus. I'm going to have to blow through this. The most common causes are the distal ileum and the proximal colon, right in here. Now, Crohn's, the inflammation you can get ulcers, and those ulcers can get deep, and they can form fistulas. You can get reactive healing, where you get a lot of thickening of the cell wall. If you take pictures of severe Crohn's, you can see where the skinny little parts are where the wall is thickened and the lumen is narrowed, and the barium is just barely making it through. Here's a case of Crohn's that could be in the same patient. And if you didn't know anything about it, you would take a layman, would you say, do these look the same? And you say, no, they don't. They look very different. But these Crohn's patients could be from the same patient. Right here, you're seeing serpiginous ulcers. That's a hallmark of Crohn's disease. You see these sites of ulcers and you start thinking, okay, you're going to make the subjective call, this patient has Crohn's. And this is a gross post-resection specimen. Okay. More serpiginous ulcers in the terminal ileum. Some lesser involvement, just involving the ileocecal valve. Here's some deep ulcerations in the sigmoid colon. Now, why does Crohn's disease involve the terminal ileum and the sigmoid? Well, some people might say, well, that's where the stool stasis is. Well, possibly it. I've heard another hypothesis is that's where there's more M cells. And M cells are the cells that sample components of the lumen and bring them in. And it may be through the M cells, well, it is through the M cells that certain bacteria invade, i.e. MAP. Here's an well, this is a little aphthous ulcer on the tongue, the Crohn's patient. Here are just little bumps in the duodenum, that proximal part of the small bowel just south of the stomach. This is a strong argument that the most accepted explanation for Crohn's disease is that it's a dysregulated immune response against commensal bacteria. They're not commensal colonic bacteria up in the duodenum. So this is a systemic disease. In Crohn's disease, when you do a resection, is more apt to recur right there at the anastomoses. This is at the biological level of the organism. This is what some Crohn's patients can look like. Other Crohn's patients look absolutely normal. Wide spectrum of disease manifestation. That's the point of this slide right here, so I won't belabor the point. They can come in with they can be asymptomatic, they can come in with diarrhea, abdominal pain, fatigue. So when you're treating patients and looking for response and looking for patients for studies, it's difficult, it's a very difficult disease to follow as far as responses go. Test, history, physical, CT scans, barium studies, colonoscopy, and then the doctor makes the call and labels the patient's Crohn's disease or not. There's a differential diagnosis, most of which are infectious, and then the doctor makes the diagnosis. Sort of it's regional, depending on where the doctors are. I was working in upcountry Thailand, and a surgeon threw up a slide, an x-ray, and said, "Hey, what do you think this is?" And I said, "It's Crohn's disease." And he just looked at me and said, "It's intestinal tuberculosis." And I said, "Well, how do you know?" And he said, did you test for it? And he goes, "Why?" I mean, it was just that. In other words, the mycobacterial disease. Treatments. Okay. Let's see. At any rate, we've clipped off the top part. But your basic treatment pyramid is you'll start with 5-ASA drugs, which are anti-inflammatory and do affect the immune system, perhaps through dendritic cell alterations. You can give a budesonide, which is a non-absorbable corticosteroid. And at the very bottom, always one of the standard treatments has been treatment with antibiotics. Now, the accepted treatment is with ciprofloxacin or metronidazole. Nobody really had a good reason why those worked. They just seemed to work, and they talked about it. Okay? Now, both of those are effective against Crohn's disease, against MAC. Then you can move on or quickly bring symptoms under control with the oral corticosteroids. The problem is the side effects. If you're on oral corticosteroids for any amount of time, you'll end up with cataracts, with metabolic changes, with steroid-induced diabetes, with osteoporosis, thinning of the bones, secondary infections. Steroids is not something you want to be on, and there's beginning to be a recognition, that if you're on steroids, that is an independent risk factor for a downhill long-term course of Crohn's disease. So you want to stay away from that. They move on to 6-mercaptopurine, which is a purine analog, interferes with DNA-RNA replication, inducing apoptosis, and if somehow it modifies the immune system, immune modulator. Robert Greenstein showed that in vitro, at any rate, it's an anti-MAC drug. Then at the top of the pyramid, they've got the biologics. Antibodies against specific molecules, antibodies against tumor necrosis factor. Nobody knows how that works. It does alter the immune system. This immune networks change, and patients do get symptomatic relief. It also causes apoptosis of activated macrophages. I'm going to hypothesize that it may work by killing the macrophages that are infected by MAC. That's another explanation, certainly not proven. I've covered the history right in here. What's the evidence for MAC? Kimball did a great job. I want to talk about blood cultures. Here's a picture of Crohn's disease and Johne's disease. In these two patients, they look the same. Okay, complete with creeping fat. I want to say that there's an awful lot in our literature that doesn't take into effect the broad spectrum of clinical manifestation of Crohn's, doesn't take into effect the intraspecies variation of how host responds to this pathogenic mycobacteria and what the clinical presentations are there. Meta-analysis showing the presence of Crohn's, presence of MAC and Crohn's disease, except for two big outliers. Everything seems to be showing that MAP is associated with Crohn's disease. But to me, the kicker is blood cultures, Solly Nasser, blinded study from Florida. Half the patients had Crohn's disease circulating in their macrophages. He did not know what tubes he was testing. I sent him to confirm that 19 patients, 9 of which were positive, none of the controls were positive. He did not know. So whatever he's doing is a great marker for Crohn's disease. And not only does he culture it in the MGIT system, liquid media, show after 6 weeks that sort of beefing up the presence of MAP, then plating, he then plates it out, and these turn positive. Okay, now, this was just published. 2 other labs Mike Collins